I'm Dr. Cassi from NAVC's Vetfolio and the host of Vet2Vet. While chronic kidney disease in cats is commonly on our radar, ureteral obstruction may not be. Thankfully, advancements in the last decade mean there are more options than ever for treatment, including the subcutaneous ureteral bypass device, or the SUB. We're joined today by Dr. Weisse, one of the developers of this device. He's the service head of interventional radiology and endoscopy at the Schwartzman Animal Medical Center. Dr. Weisse, it is so great to have you here with us today. I understand the Animal Medical Center conducts a great deal of clinical medical research, and advancing treatment of conditions like CKD happens to be one of the things that's happening there.
Yeah, thanks for having me. I appreciate the opportunity to speak to my colleagues about this. It's a very important subject and something we're still learning a lot about. Certainly, there's a lot of different research that's being done at the Animal Medical Center, and even a lot of research that's being done, clinical research, through the interventional radiology department. A lot of these are very new techniques, so we're describing the techniques, and we have clinical trials going on. And CKD is one of the more common cases that we see because it's so prevalent among our cats as well as dogs, and there's a lot of interventional options we have for these patients.
That's really exciting because, like you said, CKD is very common. It's something we're always on the lookout with our cats, especially as they're getting older. When you and I first spoke, though, the topic of our conversation was really ureteral obstruction, which, I'll be honest, is not something that crosses my mind regularly when I'm thinking of cats with CKD. How common is ureteral obstruction in these patients?
Yeah, well, that's a really good question. I think that's one of the reasons that we're very excited and interested in trying to get this information out there because we don't really know. Probably about a third of geriatric cats will develop CKD. And I think as referring veterinarians do geriatric blood work in this cat population, they see elevated creatinine levels, and they just assume cats have chronic kidney disease. We've done some studies on stem cell therapy in cats with CKD, and in order to be admitted, one of the inclusion criteria to be in this study was that they couldn't have a ureteral obstruction. And what we found is a lot of people were calling us with cats with CKD, and they needed to get radiographs and ultrasounds to prove there were no ureteral obstructions. And the majority of those cats that we saw for this study ended up not being able to be included because they had ureteral obstruction. So we still don't know how common it is, but you're right. It's not a kidney disease necessarily all the time. It's a ureteral disease. And we know that as the ureter becomes obstructed, it tends to cause damage to the kidneys. If we could relieve the ureteral obstruction, we could save the kidney, and that's a really important thing to do in these cats.
Wow. So you said the majority of cats had ureteral obstructions and couldn't be admitted to this study. I know that we don't know the answer to this question, but just curious about your suspicions. Do you feel like that was a population type of finding, or is this something we really need to be on the lookout for much more?
Yeah, I think that may have been a population there, bias there, because I think we have a lot of clients that have a lot of resources and really want to get to the bottom of what's going on with their patients. So a lot of them take the extra steps to do the extra diagnosis and diagnostic testing. But we really recommend in any cat, just so we don't miss it, to get if you're suspicious of chronic kidney disease, to take radiographs and do an ultrasound. In our original study, when we were putting these ureteral bypasses devices in, probably 40% of our cats or higher had stone disease. That was, these stones are almost always calcium oxide stones. They're made in the kidney. They obstruct the ureter. So you could see those on your radiographs. You have to look where the ureters are because they're very small often. But if you don't see stones, that doesn't mean there's not an obstruction. So they could have blood stones that are not radiopaque. They can have strictures or circumcaval ureters with strictures. They can have pyuria that leads to ureteral obstruction. So it's not just stones. If you don't see stones, that doesn't mean it's not a ureteral obstruction. That's why it's also important to put an ultrasound probe on the kidneys and make sure you see that they're not dilated.
Sure, that makes a lot of sense. I mean, we know their cats are constantly creating substances to obstruct their urinary tract. So really being on the lookout and identifying that. We're talking about CKD cats, which I'm suspecting we're talking about identifying CKD on blood work. But, of course, with SDMA, we find these a little bit earlier, but we have to lose a substantial amount of kidney function before these values start to change. So is this something that we should be looking for maybe in cats who aren't azotemic?
Yeah, absolutely. You're absolutely right. So just because you don't see azotemia, we don't see animals get azotemic until 75% of their kidney function is gone. So you could remove or have an obstructed entire kidney that's totally obstructed, not making urine, and that patient won't have azotemia unless the contralateral kidney is damaged, obstructed, or damaged also. So yeah, you're absolutely right. Just looking at those values is not sufficient. You should palpate both kidneys because often one might be small and one might be large. In our study, about 40% of the obstructions were bilateral, but 60% were unilateral. So you may just have a unilateral obstruction and you may not always know it because the creatinine may not be elevated or the SDMA. So you definitely want to look at that. You also want to look, we see a lot of idiopathic hypercalcemia in cats. Those animals at risk for making stones, calcium oxalate stones. So when you start seeing cats that are hypercalcemic, you want to look to see if they're creating stones.
I always love having these talks because it's these subtle findings that kind of will cue us in to look a little bit deeper. And I'm glad that you said that about losing one whole kidney because in my head, I know, 75% loss before we see BUN and creatinine start to rise. But when you put it in those terms of you could lose an entire kidney's worth of function and still have a normal creatinine, I mean, I think that really puts it in perspective that we need to be looking for these patients.
Yeah, and that brings home another point that I think is really important for your referring veterinarians and colleagues that are watching this is that if you have a patient that comes in with a unilateral ureteral obstruction, it's actually uncommon for the kidney to be completely obstructed in cats. We see that maybe more in dogs, but in cats, it's usually a partial obstruction, and that backup of urine leads to pressure on the kidney, and that pressure leads to reduced blood flow and decreased GFR, and the damage is being caused, and the function is going down. But it's really important if you have a unilateral obstruction and an azotemic cat or dog, you don't remove that kidney. Because if the animal's azotemic, it's already telling you that the other kidney is not functioning well. So the last thing you want to do is take out the kidney that's obstructed when they're already azotemic because you could just make the azotemia worse. Additionally, if they're stone formers, we know that animal's at risk for developing stones in the contralateral kidney. So you really want to save as much of the kidney function you can. And that's why you want to unobstruct these ureters and save as much of the kidney function because often these are chronic. You've already had hypertrophy of the kidney function that's available. So these aren't just regular kidneys that get acutely obstructed. Often they're already damaged, and then they're getting more and more damage from the obstruction. They've tried to hypertrophy and increase their function, so they're at peak performance. So if you take them out now, you can't really expect them to get much better.
So I'm glad that you bring that up about the bilateral disease because I'll admit I'm not a surgeon, so nephrectomies are generally not something that's on my radar. But I think you make a really good point. If we see this very diseased kidney, the reaction can be, well, let's get rid of this diseased organ that's causing a problem. But if you have an azotemic animal, of course, there's your evidence right there that the disease is bilateral and cats need all the kidney function that we can give them.
Yeah, absolutely. The last thing you want to do is take a kidney out of an animal that's azotemic. And I think there's a misconception when you see an ultrasound of this big dilated kidney and this rim of tissue that you can't save that kidney. And we can just show you picture after picture of this big dilated kidney that gets better after you relieve the obstruction. The pressure is compressing the parenchyma, so it looks like a little rim. And as soon as you decompress it, you can see that come back. Really takes about 3 months for the full function to come back, but the kidney can look a lot better. So please avoid taking out the kidney. There are certain circumstances with kidney tumors and things where you'll have to take them out, but for the most part, we try and avoid that. So that's one point. I think the other thing to mention is it takes a little while for these kidneys to get distended. And sometimes you'll see maybe a not so distended kidney, and the cat comes in with a creatinine of 20 or 25 or 30. And people will say, well, sometimes you could save these, but not when the creatinine is high. And that's actually just the opposite, because animals don't live for a long period of time at such a high creatinine. So it tells you that this is a relatively acute issue. And if it's acute, that it went up that high, it can actually acutely come down as quickly. So when we see cases that have those really high creatinines, we're usually pretty hopeful that these are animals that are going to drop really fast. And those creatinines, once you unobstruct the kidney, tend to drop about half every day. So you might be at 25 and then 12 and then 6 and then 3. And they can really recover very, very quickly and sometimes go totally back to normal.
That's amazing. Like I said, not a surgeon, but the internal med nerd in me really gets excited about those high creatinines sometimes, because it is so rewarding that if you can find that underlying problem and you can treat it, how, like you said, it drops so quickly and the cats generally start to feel better. Now, along those lines, I'm picturing like, acute kidney injury, maybe not necessarily from a ureteral obstruction, but since we're maybe learning that these ureteral obstructions are more common, how would we go about diagnosing that? I know you mentioned radiographs and ultrasound. Can you give us a little bit more specifics on what we're looking for, or any other tests we should be aware of?
Yeah, so in general, I think the first thing to understand, and you mentioned this, but just I want to make sure this point isn't missed, is that this is often a ureteral problem, not a kidney problem. And when you think about kidney problems, you often think, oh, there's nothing we can do to fix the kidney. But when you have a ureteral obstruction, you can fix it and help the kidney. So the best way to evaluate this is with blood work, radiographs, and ultrasound. Some people want to do CAT scans. Some people want to do hyalograms where they put a needle into the pelvis under ultrasound, put contrast in. Those generally don't tend to be very fruitful. There's complications associated with them. So one other thing to keep in mind is that these pelvises don't have to be very big. Often we're treating 2-3 millimeter pelvises. But if you imagine the kidney like this and the ureter coming down, the pelvis looks like this little smiley face here. And sometimes in people, they talk about an intrarenal pelvis versus an extrarenal pelvis. An extrarenal pelvis is kind of sitting outside the kidney, and intrarenal pelvis is inside the kidney. And sometimes patients have these intrarenal pelvises that don't get very dilated because of the hard, firm kidney won't expand. But you'll see the ureter dilate. So it's always important when you're ultrasounding this, even if you don't see a big dilated pelvis, watch the pelvis and follow it down to the ureter, because the ureter doesn't have anything constraining it. And if you see the ureter fairly dilated, 3-4 millimeters, that tells you there's some resistance to flow. And if you follow it down, then all of a sudden it disappears. That tells you whether there's a stone there or a stricture or something else, that there's likely an obstruction, even if the pelvis isn't very dilated. So we're really looking at the pelvis, and we're looking at the ureter, and seeing if there's an abrupt change in ureteral diameter. We don't typically do CAT scans. Some people do, but we don't like to give these animals contrast, put them under anesthesia if they don't need to be, because we get enough information from those other tests.
Absolutely. Are there guidelines for ureteral dilation? I know you mentioned 3 to 4 millimeters. Is there kind of a published parameter for what the diameter of a ureter should be?
Yeah, so I mean, a normal cat ureter is about 0.4 millimeters. So in general, when you're ultrasounding a normal ureter, you shouldn't see it.
Okay, that makes me feel
Now, there
better because I
can
usually
be,
don't.
yeah, you shouldn't see it. So if you see it, now you could have infections and inflammation, ureteritis that might make it a little bit dilated. And there are some cases where you see some dilation of the ureter, and it could have had an obstruction that passed spontaneously. It takes a while for the size to get smaller. But when you see it dilated and then normal, or it disappears, that tells you that there's resistance to flow. And that resistance to flow that's making the ureter get dilated is increasing pressure, and that pressure is causing, reduced blood flow in the kidney most likely. So There are ACVIM published guidelines on the management of ureteral obstructions in cats and dogs.
A big reason for making sure that we're having this conversation here is to talk about therapy for ureteral obstructions and particularly subplacement. If we find a ureteral obstruction, is every patient a candidate for a subplacement, or are there certain parameters where we would say this would be the right patient for this procedure?
Yeah, so in general, cats tend to respond very well to sub placement, and sub is the subcutaneous ureteral bypass device. And this was a device my wife, Dr. Alison Barrett, who's an internist, and myself worked on for a number of years. We developed this device and then worked with Norfolk Vet to make this device available. And the idea was the way this started was we were seeing a lot of ureteral obstructions in cats. And what we found is there was a lot of complications with traditional surgery. I was fortunate to do my training at Penn, University of Pennsylvania, where we have transplant surgeon, but most places don't have those available. And even in really good surgical hands using microscopes, there's a lot of complications with cutting open the ureter and trying to repair it. Even if you do a great job, there could be a stricture where you took the stone out that it could restricture. We say once a stone former, always a stone former. So you they may have multiple little nephroliths already in the kidney that can just drop down 2 days later and reobstruct it, or they'll continue to make stones even if you're managing them. So we started looking into ureteral stents. And stents are double pigtail stents. It's a little loop with a shaft and another little loop, and we would put that in the ureter to allow urine to bypass the stones. And if other stones came down, urine would still be able to go around them. We actually developed a cat ureteral stent, and we use ureteral stents in dogs all the time, and they actually work very well for ureteral obstructions in dogs, whether it's a malignant or benign obstruction. We usually put those in endoscopically in dogs, so they don't even need surgery. Cats, the stents are much harder to put in. And what we found is that the stents worked well, but there was a lot of dysuria in some patients from having the stent sitting at the trigone, right where the ureter comes in. And people complain about lack of urea and discomfort with ureteral stents as well. And then also, they were very difficult to place. And what we found is in some cats that were really, really sick, we would put nephrostomy tubes in. And the nephrostomy tube basically looks kind of like this. This is a kidney, and there's a tube we put that curls up in the kidney, and this is just externalized outside the body wall. And you drain the kidney, make sure that the obstruction's relieved, and then we let that animal recover. But then what we're doing is really kind of dooming them to need a second procedure to internalize that and fix the ureter once rhizotomia is resolved. And we found that animals, just like people, do so well when you divert the urine. Instead of diverting it to a bag outside of the patient, we said, why not just divert it to the bladder inside the patient? And that led to the development of the sub. So we put a catheter in the kidney, we put a catheter in the bladder, and we connect them inside the belly. And then we have another catheter coming out to a little port that's under the skin so you could sample it. You can flush it to make sure it's patent. You could put disinfectant in. And that's the idea of the sub. So we don't have to worry about cutting around this tiny little ureter. You don't need to be a transplant surgeon with a microscope. We use fluoroscopy or video x-ray to place this. Some people are placing it with ultrasound guidance. So this device has really allowed access to many more people with local surgeons who can place these. So you don't have to drive across the country to try and find a transplant surgeon for these cases. So we feel that a lot of animals have been able to benefit from this.
That is very cool. And I love it even more that you and your wife developed this together. And you mentioned she's an internist. So, your surgery expertise and her internal med mind coming together and making what sounds like a really interesting device. So, if I'm understanding it correctly, it's almost like that nephrostomy tube, but instead of diverting out of the patient, instead it goes to the bladder so the cat can continue to urinate fairly normally. And then they connected a subcutaneous port so you can maintain those tubes that are going to the kidney and the bladder. Is that right?
Correct. So
Very cool.
that way you don't have to worry if more stones drop down the ureter or there's a stricture and you don't have to do surgery on the ureter and worrying about causing another stricture or getting leakage because it's so much easier for most surgeons to place a nephrostomy tube and putting a cystostomy tube in, and just connecting them with this device really makes it a much faster surgery. We know this is a very quick surgery, usually takes an hour or less. These patients, 95% of them leave the hospital. They're usually in the hospital for about 4 days. It's really been a game changer for us.
You mentioned 95% leave the hospital, which I'm sure some of these patients are really sick. So that sounds like a raging success. What about long-term prognosis for these patients? Do the devices stay in place? Do they need to be replaced? Do they clog? What do people need to be aware of with a sub placement?
Yes, that's a good question. We've learned a lot and we've developed multiple iterations since the first prototype of the sub. So now we're on the sub 3.0, it's the third version of the sub. What we found initially was that the catheters could kink when they went through the body wall. And that's why the whole system is internalized into the belly now instead of the nephrostomy coming subcutaneously and the cystostomy coming subcutaneously. They connect inside the abdomen, and there's just a different catheter coming out. So if it kinks, it doesn't interfere with the flow of urine. So mineralization, occlusion occurred in maybe a quarter of the subs initially. And that was higher in animals that were stone formers or hypercalcemic. So those need to be watched a little more closely. What we found in those patients was that now that we're using tetra-EDTA, which is called T-Flowlock, which is a medication that dissolves, it binds the calcium and the oxalate, it decreases biofilms. We've reduced a lot of the mineralization that occurs in these patients, in these stone-forming patients. So that's really dropped the number probably to maybe 10% of them get occluded. And even if 10% get occluded, it's really interesting that only about half of those need to be replaced, because even if the sub gets occluded, what happens very often is that the ureter becomes patent again over time. So in people who have ureteral stones, we've all heard how painful ureteral stones are. And one of the things is the stone moving down the ureter, which can be very uncomfortable. The other thing that's really, really painful is when the kidney's obstructed and you get distension of the kidney and the renal capsule. That's where a lot of the nerve fibers are. So people come in when they're really painful, distended kidneys. And if you put a nephrostomy tube in, they often feel immediate relief in the pain. And once the pain stops, the ureteral spasm stops, and the stone sometimes will just spontaneously pass. And we see that in cats and dogs too, that once we relieve the obstruction, often the ureteral spasm will stop, the stones will pass. So even over years and years, if the sub eventually gets obstructed, only about half of those actually need to be replaced because the ureter has often become patent again.
Oh, so a small percentage of cats that we're talking about where this mineralization does cause obstruction. And even when it does, it's an even smaller percentage where we have to actually go back and replace the device.
That's correct. We also saw infections were more of a problem early on. What we realized then was that we no longer use urinary catheters in these patients, because if they have urinary catheters in to watch urine output, we get bacteria go up the urinary catheter and seed biofilms on the sub. So now we avoid urinary catheters in all of these patients to avoid infection and biofilm formation, or at least reduce the likelihood of it occurring. The T-Flowlock, which degrades the biofilm, and we monitor these animals serially because they often have CKD. So for the first couple of years, we're checking them every 3 months. After that, every 6 months. And if they're just sailing along, maybe even last once a year if they're not azotemic. And now chronic infections are probably 5% or less.
Wow, considering the patients that we're talking about, that seems like a really low percentage. It makes me think of patients with other devices that are implanted, like a TPLO plate or something like that. Are these patients where if they had to have some other type of surgery, for example, a dental cleaning, or, we get them healthy enough where they can withstand and benefit from a dental cleaning, do we need to be thinking about prophylactic antibiotics in these patients?
I would. I think that's a
Okay.
good idea. I think that's a smart thing to do. It's pretty easy to do. It's pretty safe. But you're absolutely right. Any animal or person with implants, we worry about the temporary bacteremia after surgery, um, or dirty surgeries like dental. So yes, I think that's a very reasonable thing to consider.
And if we have them healthy enough that they need a dental cleaning, then we've done
That's
our
right.
job, then we have a
Yeah,
success.
correct.
What about talking to owners about sub placement? Of course, pet owners, many of them want to do everything that they can to help this patient, help their pet. But when you mention the idea of surgery, sometimes that can kind of get this recoil response of, well, I don't know if I want to put him through surgery, especially if we're dealing with maybe an older patient or something like that. So how do you recommend communicating with clients about the option for subplacement?
Yeah, you know, it's a great question, and it's a difficult thing to answer because different people have different experiences. You can quote our paper, but your results might not be like our results. So you really need to talk to your veterinarian. Are you familiar with the sub? Is it if they're not familiar with it, they may not realize how successful it's been. So you need to talk to somebody. It doesn't cost a lot to just get a consult. If you have a consult with someone, you need to find out what's your experience with the sub. Have you placed them before? What do you do instead? What are your results? I don't, the sub works really well for us and it works really well for a lot of people. Some transplant surgeons still feel like they prefer to just do open surgery. And if you have really good success with open surgery, then do it by all means and ask the surgeon, what is your success with these cases? If you have really good success with stents, then use stents. If you have really good success with subs, then use subs. But I think you need to probably get a couple different opinions, ask people what their training's been, what their individual success rates are. You don't want them just to quote the papers that you could pull up online. You want to say, well, I know that's what happened with the results of the people who developed this product, but how often do you place these? What are your results? Are they similar to what's been reported? And I think getting a couple opinions is a really good idea. We do a lot more of these now. We used to, when I went through my residency, in the 2000s, very early 2000s, if we saw a unilateral ureteral obstruction in a cat that was not azotemic, we wouldn't do anything, because we knew we could make them a lot worse because surgery has a lot of complications. Now we're treating non-azotemic cats because we know as this cat gets older, if it's developing stones, the other kidney might develop stones. So we're treating these animals that may not even be that sick. They may have come in and vomited once and you notice a ureteral obstruction. Now we have such a safer alternative that we're treating animals much, much sooner and saving that kidney function over time. But it's it's just a total change in the conventional wisdom of how you manage this. We happen to manage a lot of them, so we have a lot of experience with them. So you want to go somewhere where people have a lot of experience doing them, if you're able to.
And I think you offered a lot of encouragement there for veterinarians doing what works in your hands. Getting the experience and finding your comfort level with the technique where you see the best results, and that the sub offers a really great additional option that we can use to manage these patients. That, like you said, the other management options to this point maybe haven't been great, and so this is another option to get experience with and learn to use to help benefit these ureteral obstruction patients who now we're learning maybe are more common than we initially thought.
Yeah, and I think going back to the early days of my residency when there weren't really a lot of medical devices for soft tissue surgery. Now there's stents and catheters and plugs and coils and subs and stents, ureteral stents and metallic stents, tracheal stents. There's all these devices that are now available. People who are doing surgery now may not be trained on them. So it's important they get trained on them because if you talk to your local veterinarian and they say, "Oh, tracheal stents they don't work or subs don't work," I sent a couple patients out for them. If people weren't trained on them, they're going to get a bad name. It's not the device. It's probably the person may not have had a chance to get trained on the device. So it's really important that we um, more and more people place these, more and more people publish on their outcomes, and our colleagues that are watching watching this video eventually call their referring vets and their referral surgeons and stuff and say, what do you do for these? What's your success rate? Because I see these cases and I want to know, do you have good success? And they say, well, I don't really know. I've done a couple, they haven't gone well. Maybe that's not the right place to send them. It doesn't mean that the device doesn't work. Maybe you need to go a little farther or find someone else that can place them, because general surgeons have a lot to do. They're doing ortho, soft tissue, neuro. There's all these new devices coming out. So it's important people find the right person to help them manage, because these are tough cases sometimes.
Absolutely. I think that's a really good message. And I think it's fascinating. I love talking about kidneys. My mentor, before I went to vet school and in vet school, he helped start the hemodialysis program at the University of Florida. So we talked a lot about kidneys. How did you become interested in this research?
Yeah, well, it's interesting you say that, because I got interested in interventional radiology as a surgeon, placing stents for tracheal collapse and
Okay.
vascular issues. And we saw a ton of urogenital stuff because we were at a hospital that had a renal transplant surgeon and dialysis. My wife's an internist and she was really interested in endoscopy and endourology, and we started working together. And so she would scope and I would do surgery, and she taught me how to scope and I taught her how to do surgery. So we would do these cases together, and it kind of just developed in finding the best fit and how to help these things. But when we were recruited in 2009, 2008 to come up to the Animal Medical Center, they had a very active dialysis program. Most of the animals they were dialyzing were animals at that time were animals with ureteral obstructions. And they would dialyze them to get the azotemia down and give it time for hopefully the obstruction to pass on its own. But once we came up here and started doing these obstructions, dialysis just sent them all to us. So they started just dealing more with the chronic dialysis, the antifreeze, all the other issues you see with the requirements for dialysis and things. But really, a lot of the dialysis cases ended up going to us because so many of them were the ureter, not the kidney.
I think that really tells us out there to be on the lookout for these. And I appreciate the pointers that you gave on ultrasound to identify that ureter, that, if we're seeing it dilated coming out of the kidney, to have that on our radar and start looking for reasons for that in our patients so we can make good recommendations, because these patients may have more longevity than we think.
Yeah, and it's important. We try and talk to the radiologist when we can too, because if you're sending one of your patients out to a radiologist for an ultrasound and you're worried about the kidneys, you need to ask them to comment on the ureter. Because most of the time, most radiologists don't know that. They don't look at the ureter. They look at the kidney. They may say, 2, 3, 4 millimeter pelvis, even though that may be about half the cases we end up treating. They may say, it might just be because the animal's been on fluids. It may be because it's got a little ureteritis or a little pyelonephritis or something. But if they don't follow that ureter down and see that it just abruptly stops, they'll miss that. So you need to put it on your request when you're requesting these ultrasounds to be done.
Very interesting. Things I wouldn't even think of when sending a patient to have a diagnostic ultrasound like that. So something to keep in mind to make sure that we're communicating that this is a possibility, and can you please take a look and just let us know if you see anything.
Yeah, very important.
Well, this has been a fascinating talk. Like I said, I love talking about kidneys, and I love the idea of there being another option for both diagnosis and treatment in these patients that can really give them good longevity and good quality of life. So, Dr. Weisse, thank you so much for joining me. Any final thoughts you want to share with everyone?
No, not at all. I appreciate the opportunity to speak to all of our colleagues who will be watching this. And, I'm available. I don't know if my email will be shared here, but, I want to thank my wife, Dr. Brent, for helping develop this product, and thank the folks at Norfolk Vet for helping making this, sponsoring this talk, and helping get this sub out to our veterinary community. And if you have any questions about this device, feel free to give me a holler and reach out. I'd be happy to talk to you about it. Myself or the folks at Norfolk Vet could probably refer you to someone in your neighborhood, wherever you might be calling from or emailing from, that has experience and training to place these.
Excellent. Well, thank you so much for all the great information and for making yourself available for questions. Really appreciate the talk.
Yep, my pleasure.
And thank you to Norfolk Vet Products for partnering with us for this edition of Vet2Vet. Check out NAVC's vetfolio.com for more of our V2V discussions on various topics in veterinary medicine. And remember, if one animal is better off because of you today, it's a great day.